हेलो। यस सर। ठीक है सर। हाँ कोई बात नहीं, मैं हूँ सर अच्छे से। हम्म। ठीक है। हम्म। ठीक है सर। अच्छा मुझे अब आगे क्या करना होगा? हाँ हाँ। हाँ। अच्छा अच्छा। अच्छा अच्छा।
Hello. Hello.
Hello.
Yeah, can you hear me?
Yes, sir. I can hear you, sir.
Yes, yes. Just check. Yeah.
Sir, can you share your screen for just checking purpose?
Yeah, no issues.
Sir, to the bottom, share a screen and open your PPT.
Yeah, I don't. I know it. Just wait.
Okay, sir. Okay.
कहाँ PPT कहाँ है? PPT किसका? इसमें ना PPT कहाँ पे है शेयर करने के लिए?
सर कोई भी दिखा दो चले, बस चेक करने के लिए कोई भी चलेगा. ओके सर, चल रहा है तो PDF फाइल खुला है. ठीक है सर.
Yes, sir. Yes.
हेलो। हाँ, यूट्यूब लाइव कर दिया क्या ये?
हाँ सर, यूट्यूब लाइव में है। यूट्यूब लाइव है सर, यूट्यूब लाइव है। यस सर, यस सर, यस सर, यस सर।
Hello.
Good afternoon, Dr. Stankovic. I'm Dr. Parvinder Singh. Welcome.
Oh, thank you for invitation.
It's a pleasure, sir. We're looking forward to it. We'll just get things organized, sir. There's still
Okay.
10, 12 minutes to go to start.
Sure, but it's better to connect safely and test the slides.
Absolutely, sir.
Yeah. Should I try to test the slides now?
Yes, surely.
Is it okay?
Yes, perfectly fine.
Can you see everything? Yes, you do?
Yes, we can see the video also.
Okay. So I'm ready.
Great, sir. Great.
I'm ready.
Good evening. Hello. Good evening, everyone.
Hello.
Hello, Dr. Goran. How are you?
Perfect. Let me.
So, how are you doing?
Waiting for the meeting to start. We just finished a very tiresome PCR.
Yeah.
Plenty of things to do, so it was not really simple this week to prepare everything. Okay. But at the end, I'm very happy.
So, how's the COVID there at your place?
It's currently it's in stable phase. We are doing really better than a couple of weeks ago. Number of cases, new cases is really decreasing significantly, and they expect from the mid-June to relieve some of the extreme measures. So at the moment they give a possibility for 5 people to be together. Okay. So you cannot make really meeting with more than 5 people, but it's, you know, they open shopping malls for a restricted number of people to enter. Sort of normalcy is getting back, but you know, when they did it in January, we immediately had in a couple of weeks extreme rise in the number of new cases. So I don't know. I'm afraid to anticipate anything any longer. So very difficult. But compared to India, I cannot say anything. We are perfect. And vaccination is not so bad because we are, I think, in the range of 44% of people above 18 vaccinated. So 44%, it's better than it was before.
44% is also good enough. It's not that bad.
Yeah, it's not that bad. And in Belgrade, they say, in the capital where I live, they say that it's even higher. So I guess, by the end of summer, I guess that we will have enough for a sort of little bit more normal life to live from September. I don't know. We'll see.
Good evening, Dr. Matthew.
Oh, hello, Dr. Matthew. I didn't see you for such a long time.
But I was listening to you.
Thank you. When you start talking, then I saw you. I really apologize. So we are fighting as well as you with COVID here in Belgrade. It's getting slightly better, but still far from being optimal.
I don't think anybody would be as bad as us.
No, it's incomparable. Yeah. More than 300,000 cases. It's really unbelievable. I don't know how you are able to give the oxygen with
That's in India, where politicians become cardiologists, epidemiologists, everything. So, the incompetence they have.
How is the situation in Chennai? Is it good?
Bad. It's very bad.
It's bad, very bad. Oh, I'm sorry. I thought it's close to the seaside, so maybe it's warm and not good for the virus to survive.
Our virus is well trained.
It's well trained.
Even Madras, Bombay, all are near the sea, but no reprieve.
No. So definitely we don't need your virus in Europe. As you said, it's too well trained for us.
Yeah, it's
But this time virus is very virulent and more infectious.
very, very.
And actually the upsurge of mucormycosis is only because of increased virulence of this strain. The people who are surviving, they are surviving with a very high dose of steroids, and ultimately they are developing this mucormycosis.
As you said, they have so many new strains adapted so quickly to local climate and changing genetic presentation, very difficult to.
Hi, Mahesh.
Yeah,
And Virender's also here.
this is joining. And I think we can start now. It's time. And a warm welcome to you all, sir, from Cardiology Next 2021 academic wing of Baroda Heart Institute and Tricolor Hospitals at Baroda. Today we're going to focus on left main interventions. And for a long time, as we all know, it has been the sole domain of the surgeon. But over the years, things have changed. Enterprising interventional research trials, newer imaging modalities, newer generation of stents, and other technologies and techniques. Now it's been on the radar of the interventional cardiologists. Today we have with us some of the most renowned interventional cardiologists in the world, teachers, professors, who would help us to understand this. A very warm welcome to Dr. Goran Stankovic from Belgrade, Serbia, Dr. Samuel Matthews from Chennai, Dr. Praveen Chandra from Gurugram, and Dr. Ankush Gupta from Jaipur. We have with us a top-notch panel of cardiologists from Dr. Anand Shukla from Ahmedabad, Dr. Apurva Vasavda from Surat, Dr. Bhupesh Shah from Ahmedabad, Dr. Gaurav Gandhi from Jamnagar, Dr. Girish Kautikar from Indore, Dr. Jaideep Desai from Rajkot, Dr. Ketan Kapasi from Baroda, Dr. Prakashvit Parikh from Ahmedabad, Dr. Prashant Jagtap from Nagpur, Dr. Suhas Lele from Baroda, Dr. P.C. Chauhan from Baroda, and Dr. Varun Sibbal from Bhavnagar. Our first talk would be by Dr. Gaurang Stankovic, who will be talking on the contemporary approach to left main bifurcation PCIs. Dr. Gaurang Stankovic needs no introduction. Almost everybody knows about him. He's a professor of medicine at the University of Belgrade, chief of invasive diagnostics and interventional cardiology. He's the head of Department of Cardiology at Clinical Center of Serbia. He's on the editorial board of JAC and Euro Interventions. He's the founder member and president of the European Bifurcation Club, renowned interventional faculty at all major conferences and workshops, and is involved in major trials and publications. I welcome Dr. Goran Stankovic for his talk.
Good afternoon from Belgrade, Serbia, and thank you very much for the kind invitation. After very busy EuroPCR 2021, now we go back to continuous education, and I really have immense pleasure to share with you my personal perspective on the contemporary approach to left main bifurcation PCI. So in 2004, with Yves Louvard, Thierry Lefebvre, Olivier Darmon, Remo Albiero, and Manuel Pan, 6 of us created European Bifurcation Club. And this is the image of the first picture from 2005 in Bordeaux. And as you may see, all of us look much, much younger. And after these 16 years, we really have come a long way. We learned a lot. And the last meeting we had, if can I ask you to go on mute, please? And the last meeting in 2020, it was the virtual one because of the COVID pandemics. Like all other meetings, we had virtual meeting on October 22nd, 23rd, and after that we continue education in a virtual way. I was positively surprised that all bifurcation clubs from the world really accepted our invitation, joined us for these 2 days in order to share the knowledge, experience, and practice. And we learned a lot, and we somehow accepted this kind of virtual exchange of information, and we will try this year, if everything goes in the positive direction, to have our next meeting 8th and 9th of October as a hybrid event. Some of us will be in Brussels. I don't know for myself because I'm outside European Union if they will permit traveling. But I hope that at least Yves, Thierry, Olivier will be in Brussels, and we will have a very elegantly prepared program by the board that we are hoping to share soon. Since every year we have great presentation from coming from Indian faculty, I would kindly invite you to go from time to time to Bifurknet, our website, and check the program and upload your cases, because I believe that this year we will have competition for the best case of the year, and I always admired very much skill of Indian interventionists and very innovative solutions for complex bifurcation lesions. So please join us, and we will try to make better meeting if we have finally our faculty at least partially back live in studio in order to again restart kind of the meeting that we are used to. When we speak about left main, it's a different animal, but I would like to start with the EBC ethos of the treatment of bifurcations. And in the last consensus document just published this year, we keep our simple and safe as a strategy, limit the number of stents, and try to respect the original bifurcation fractal anatomy and try to reproduce it by implanting tubular stent and adapted Aim for a well-opposed, well-expanded stents with limited overlap. And again, the provisional side branch stenting strategy for us is the standard for treatment of the vast majority of bifurcations, including the left main. What I would like to clarify, and I would like also to hear your comments, is that when we say provisional stenting, for us, it is a treatment philosophy. It's not a single stent technique. And what it actually means, it's please try to approach bifurcations in a stepwise manner. Add layers of complexity as necessary. Stop when you achieve a good result. And of course, end up with two stents only when it's necessary. Left main is different compared to non-left main bifurcations. It has specific anatomical characteristics like a T-shaped angulation on the multi-detector CT. In normal human hearts, angulation between LAD and circ is very wide, and LAD between left main and the circ is also very wide. So there is a large proximal main vessel, which is the left main, and in most of the cases there is discrepancy, frequently very large discrepancy in the caliber between proximal and distal part of the main vessel. When we shift from the left main into the LAD, depending on the size of the circumflex, we have a significant step down in diameter, and it's not linear transition, so we need to keep this in mind when we plan bifurcation PCI strategy. It's the area prone to development of calcifications, and when the ostium of the left main is involved, it's fibrotic area, so we need to encounter that when we plan the strategy. There is no actually real side branch, circumflex is not small, and importantly, in approximately 10% of cases, there is a trifurcation instead of bifurcation. So what are those most important anatomical characteristics that we need to keep in mind? This is from the last consensus, one of the last consensus documents. We have ostium, which is oval and angle. We have large and highly variable diameter with the mean reference diameter around 5 millimeters, and John Ormiston and his team on CT showed that there is already initial curve inside the left main, so left main has a curved course. Again, from the imaging, we learned that atherosclerosis usually occurs in a longitudinal diffusion, mainly involving the lateral wall of the main vessel and extends into both branches. Angulation, as I said, is large, 70 to 80 degrees, and highly variable, and circumflex in more than 95% of cases is clinically relevant since it supplies with blood more than 10% of myocardium. From the perspective of technical characteristics, because of angulation, calcium, and plaque distribution, sometimes it's very difficult to wire, evaluate, and because of angulated takeoff, the predictability of procedure when circumflex is highly calcified and involved may impact the prognosis. Because of this difference in diameters, there is a potential for a guide wire to go behind the left main stent struts, and we need to keep in mind this discrepancy in diameter and take care of stent under expansion, malapposition. If it comes until the ostium, it's also high risk of longitudinal distortion, and all this may contribute to a long-term stent failure in the left main. So how those specific anatomical characteristics impact on the stenting technique? First, because of large caliber discrepancy, proximal optimization technique is the mandatory and the essential step of every bifurcation PCI involving the left main. And on the other side, because of the caliber discrepancy, we need to consider stent design, and we need to know the expansion capacity of devices that we have on the shelf. Because of large bifurcation angle, not all techniques of two stents are suitable for the left main. In aorto-ostial involvement, there is a high risk of elastic recoil and also high risk of longitudinal stent deformation. And because of the high risk of calcification, lesion preparation is the key. How to perform provisional left main according to European Bifurcation Club? We recommend to wire always both branches, predilate the main branch, and side branch dilatation is at the operator decision. But in case of diffuse disease, especially if there is a calcium in the circ, we recommend predilatation of the side branch as well. We select stent always according to distal reference diameter, so ostial proximal LAD diameter, and then mandatory step POT, proximal optimization. After that, in most of the instances, there is optional kissing, but for large shunt branches, for large circumflex, we recommend to do POT, kissing balloon inflation, and final POT. Then we evaluate the result. If circumflex is still compromised, then we optionally go with second stent, but in that case, kissing is mandatory. So for this is OCT and graphical presentation of this discrepancy in diameters because of the fractal geometry. So size the stent according to LAD. So you see that stent is selected according to proximal LAD diameter in order to decrease the risk of carina shift and compromise of the circ. But then it's very clear that stent is grossly underexpanded inside the left main. So we need to perform the POT, but we need to know technical characteristics of our device platforms. And these are from the famous work of Nicolas Foin, some of contemporary drug-eluting stents that we use, and different device platforms that are available, and most importantly, the expansion capacity. So, for example, if we take 3.5 large vessel Resolutonics, maximum expansion of this 3.5 is up to 5.5 millimeters. However, Onyx has also extra large vessel with 10.5 crowns and 2.5 connectors with the maximum expansion capacity close to 6 millimeters. So we need to evaluate diameter of the left main, discrepancy in diameter between LAD and the left main, and then try to select some device with the best possible expansion capacity in order to be fully opposed. From the Visible Heart Lab, this is a pig heart, and with angioscopy catheter, we look from inside how POT balloon is positioned and inflated according to proximal main vessel diameter. And you see now when we remove balloon that by using adequately sized POT balloon, we are actually able to fully oppose stent inside of the proximal part of the main vessel. And this we confirmed also by performing OCT evaluation immediately after POT. But what I would like to pay your attention is that you see that with correct position of the balloon for the POT, we are also able to open cells in front of the ostium of the circumflex, and by doing that, passing the guide wire and devices inside the circ becomes much easier. Here is the EBC stepwise layer provisional stenting algorithm. So after the POT, so when we think that optimal result inside the main branch is achieved, then we evaluate the result in the side branch. So if the circumflex is small and not disease at the ostium, we can go for keep it open principle and accept the side branch result. However, if there is either tight lesion or dissection or compromised flow in the circ, then further intervention is needed, and further intervention is after the POT and only after the POT side branch rewiring and ballooning. With side branch, we aim for achieving distal rewiring. And then after inflation of the balloon and opening of the strat, we can do kissing. We can do kissing and repeat POT, or we can just open the cells towards the circ and do repot. So kissing, combination kissing repot, or just a repot. As a result, after that, if the result is accepted, then we finish the procedure with single stent. However, if result is not acceptable, we go for provisional side branch stenting, and provisional side branch stenting, as you may see, is part of the stepwise layered provisional philosophy. So it's not a failure and it's not a bailout. It's just that we are going step by step. We add the layers of complexity and we try to achieve optimal result. At any step that we achieve optimal result, we can stop the procedure, and this is also provisional, as well as putting stent as a T-tap or culotte in provisional is not a complication, it's a regular part of the provisional philosophy. I mentioned pullback technique, and you see with pullback of the wire from the stent inside the side branch, we actually try to select one of these distal cell struts, which are widely open. I put it in green because more distal ones are actually connected with carina and we cannot fully open. So in this case, by the use of angioscopy, we are able to select one of these two excellent cells which are distal enough, and when we inflate balloon, we will shift this metal. Why it's important? If we are able to go to distal strut, by inflating balloon, we push this metal and we scaffold with the main vessel stent partially the ostium of the side branch. So then if we want to put stent, we don't need to protrude inside the main vessel stent, and we do T-stenting technique. So T-stenting does not have protrusion inside. However, if we cross proximal cell, then we don't scaffold the ostium, and then there is a gap that we need to cover with the side branch stent. So we can protrude enough to cover the roof, just the lateral wall, and then we have tap stenting, T and small protrusion, or we can pull it more back inside in order to touch the opposite wall with the stent, and we do culotte, in this case mini culotte. So distal strut results in provisional T-stenting, proximal strut, tap or culotte. After that, after recrossing, we do final kissing balloon inflation, and you will see that by final kissing balloon inflation, if we cross distal strut, what we achieve is better expansion of the stent in the proximal part of the main vessel, and as you may see, we position carina in the center, which is extremely important in order to preserve high shear stress in that area. If carina is not in the center, then it becomes a low shear stress area and increases the growth of neointimal hyperplasia, and it's also the nidus for thrombus formation. How to optimally perform final kissing in left main PCI? We recommend to select two short non-compliant balloons. Both balloons are sized according to distal reference of the LAD and the circumflex. Short proximal overlap to limit overlap just in the polygon of confluence. If longer overlap, then we need to reconsider repeat pot. And then we start with alternate sequential balloon inflation, usually side branch first, then main vessel. We keep balloons as long as possible, at least 10-15 seconds, and then deflate simultaneously. With simultaneous deflation, we position carina in the center. And here is animation which I prepared with my colleague here in Belgrade in order to help better understanding. So these are the steps of provisional left main. So according to LAD, we select stent, then we do pot in order to open better stent inside. We go in the distal cell, we perform kissing balloon inflation, and we do proximal second pot. When we remove the tissue, you will see that by doing these steps, you actually create two different diameters, bigger proximal, smaller distally, and you have excellent wide access into the circumflex. So this is provisional. However, since 2019 and the 14 consensus, we accept that in selected anatomies, we plan upfront two-stent strategy, and elective two-stent strategy may be considered for important side branch with complex and extensive stenosis, difficult side branch access, and high risk of side branch compromise. Stenting technique should depend on individual patient's anatomical characteristics, but also the operator's skill and experience. In Asia, operators are very skilled to perform good decay crush. In Europe, we more perform T-tap or culotte. So this is main difference in strategic approach to interventions. But when we actually need upfront two-stent strategy, there is nice meta-analysis from the Gioia in JACC cardiovascular interventions last year. In large group of all trials, it was stratified according to side branch lesion length in two groups, side branch lesion shorter than 10 millimeter and lesion length more diffuse, longer than 10 millimeters. What is important impression here is that if we have short side branch, two-stent strategy does not provide benefit in regards of clinical outcome. However, only for long and diffuse lesions of the side branch, there is clear benefit of two stents versus provisional. And this was confirmed recently in the definition 2 study by Professor Chen, but we need to understand that in definition 2, lesion length of the side branch was 20 millimeters. And we know from the Benesten study in 1994, in Europe at least, and stress in US, that for 20 millimeter long lesion, we cannot compare balloon with stent, and stent always provides better outcome. So for complex lesions, we definitely need two stents. And this is confirmed in DK Crush 5 trial, but to which patients does it apply? Lesion length in the circumflex in DK Crush 5 was 16 point something millimeters. 16 millimeters is not frequently seen in European patients. So the question is, what is the proportion of left main PCI patients with complex distal bifurcation and ostial circumflex extending to more than 16 millimeters? And 45% crossover rate in that study from provisional to two stents, in my opinion, is low, because for lesion which is 2 centimeter long, you cannot just inflate balloon and leave it without stenting. I'm really happy to share with you the results of the EBC main, so European Bifurcation Club left main coronary study, a randomized comparison of single versus dual stenting for true bifurcation left main coronary arteries, which we presented 2 days ago at EuroPCR 2021 with simultaneous publication in the European Heart Journal. So in this trial, we randomized 460 patients in total with stable or unstable angina patients with unprotected left main bifurcation disease Medina type 111 or 011 and both branches larger than 2.75 millimeter. It was performed in 30 European centers in the 11 countries. Lead investigator was David Hildig-Smith, and study was funded by the unrestricted grant from the Medtronic. It was designed and executed by the European Bifurcation Club, but the study device to be used was Resolutonics because of the expansion capacity. Primary endpoint of the study was the composite of mortality, overall mortality, any myocardial infarction, and target lesion revascularization at 1 year. Secondary endpoints were the components of the primary endpoint plus stent thrombosis at 3 and 5 years. So as I said, 467 from patients from 11 European countries. You see Serbia is here, Italy and the others, but I'm very happy that we were able to include patients in Serbia as well. Medtronic Onyx stent was used, there was clinical event committee, and CRO was the Cirque and Mary Claude Maurice. As I said, we used extra large for extra large vessels, Resolute Onyx XLV with 4.5 and 5.0 diameters, which could be expanded up to 6 millimeters inside the left main without deformation. And I think the key point is that we tried in the protocol to very precisely describe technical approach. Provisional approach, as I recommended, was step-by-step layer technique in accordance with EBC consensus from 2009 to 15, but importantly, POT was mandatory and kissing was mandatory. In systematic two-stent approach, we did not define the technique. We let the operator to choose, and he could choose T-tap, culotte, or decay crush. A step-by-step approach was also according to prior EBC consensus documents, but we recommended kissing as a mandatory, plus minus final pot, and separate high-pressure ostial bifurcation dilatation in both limbs of bifurcation was really mandatory step. So in general, age was 70 years. There were 80% male, 1/3 diabetes, 1/3 acute presentation. Very important, syntax score was 23 in both groups. 70% was done through the radial approach. Again, sorry, it's very important and expected that procedural duration, fluoroscopy time, and radiation dose were all significantly less in the stepwise provisional than the systematic dual stent strategy. And as I said, POT and kissing were mandatory and were done in approximately 90%, 85 to 89% in the provisional, 87% in systematic two-stent strategy. And when these 51 patients needed second stent, they received the second stent. So the rate of two stents in the provisional was 1 out of 5 patients. I could already interpret the way I see this study. When you look the angiogram, we frequently discuss between ourselves, two stents, single stent, two stents, but we don't need to prejudge. I think this is one of the main messages of EBC main, because if we do provisional as a step-by-step layer strategy, we will end up in true bifurcations of the left main with two stents as part of the provisional in 22% of cases. And we already showed with EBC2 in non-left main lesions, comparing provisional with culotte, that we need in diffuse disease of the large vessels in EBC2, non-left main, 16% of patients actually in non-left main needs two stents instead of single stent for complex disease. All these 51 patients, all of them had final kissing. So final kissing rate was 100% in two-stent strategy, 94% in systematic dual stent strategy, and final pot 81 and 84%. What are the techniques? So in single stent strategy, of course, it's main vessel stenting first. In systematic dual stent strategy, the most frequent technique was culotte. Half of the patients culotte, 5% decay crush, 1/3 T or tap. So this is the strategy. And when we look the reason for the second stent, in the provisional, it was half and half. 22 patients had dissection, 26 had residual stenosis, only 1 had impaired flow. So equally, either dissection or tight residual lesion at the ostium of the circ were the reasons to do second stent. And second stent was, again, half of the cases culotte, half of the cases T or tap, as we suggest, T, tap, or culotte as the second stent. So time has come to primary endpoint. Primary endpoint was a composite of DET, MI, and TLR, 14.7% in the stepwise provisional, 17.7% numerically lower but statistically not significant difference in favor of provisional. But we have to say, because it was superiority design, The study is neutral. Secondary endpoints were also no difference in mortality, MI, stent thrombosis. I think it's important when we speak about TLR to say 6.1% versus 9.3% in two-stent strategy. Again, numerical different, 50% lower rate of revascularization in provisional that I think should be again interpreted in favor of stepwise provisional. So, conclusions of the EBC main study: stent treatment of true bifurcations of the left main with the resolute tonics have generally good outcomes. Patients are treated equally well with stepwise layered provisional as with more complex dual stent approach, but as I already mentioned, stepwise strategy does not prejudge the issue whether we need one or two stents. There are numerically fewer serious adverse events with stepwise provisional, and only 1/5 of patients in the provisional group require second stent. So in our interpretation, after EBC main, we believe that stepwise provisional should remain the approach of choice for the majority of left main bifurcations. But I would like for yourself to compare some characteristics, and this is thanks to Davide Capodano and one of his slides, to compare the main characteristics and differences also between EBC main and DK Crash 5. Number of patients is very similar. DK Crash was published 4 years ago. EBC main, 11 sites in Europe, actually 11 countries, 31 sites in Europe. DK Crash 5, 26 sites in Asia and 1 site in Italy, Imad Sheiban. What is important? Less complex lesions were included in the EBC main. 23 was the mean syntax score versus 31, and shorter lesions, as I said, 7 millimeters in the EBC main versus 16 millimeters in DK Crash 5. We use stepwise provisional. 1 out of 5 had stent in the side branch. In DK Crash, in provisional, 45% of patients received second stent. And as I said, planned two-stent strategy was culotte, T or TAP. In DK Crash, of course, DK Crash 5. I was used in the range of 40%, which is not adequate. And there was small difference in the primary endpoint. We included all mortality, all myocardial infarctions and TLR. DK Crash 5, only cardiac mortality, only target vessel MI and TLR. So these are the rates, 14.7 versus 17.7 in two stents, and quite the opposite, 10.7 for provisional and only 5% for DK Crash in the DK Crash 5. So I'll show you for this last 10 minutes just few case examples to show you what stepwise provisional means and how we do two-stent strategy. So this is 78 years old gentleman with non-STEMI, distal 100 lesion in the left main. So EBU 3.56 French, wiring both branches, balloon angioplasty predilatation towards the circ because of plaque distribution, and inverted provisional stent from the left main into the circ. Resolute tonics 3.5 by 22 was then positioned. Track 4.5 for pot, and this is the result after pot. After that, recrossing distal cell and kissing balloon inflation. You may see 2 short non-compliant balloons sized according to both branches, and the final angiographic result in complex anatomy with calcium with single stent inverted provisional. Our algorithm for distal left main 111 or 011 is, in case of the low risk of losing the side branch, we recommend provisional and then T-tap or culotte. In case of major concern regarding losing the circumflex, we accept for experienced operator double kissing crash, or as I showed you, inverted provisional and then inverted T-tap or culotte when needed. So T and tap, again, animation that I prepared with my colleague. First steps are very similar, actually the same as in provisional. We stent the main vessel, sized according to distal diameter, then we cross, predilate, do pot, cross distal cell, and then do kissing. And after kissing, we go with stent into the side branch to fully cover the ostium, balloon non-inflated in the main vessel. We deploy stent, do kissing, and far away from the metallic neocarina, we do final pot. And now you see in blue, this short metallic neocarina is actually the consequence of small protrusion in the tap stenting technique. In T-stenting, there is no protrusion. So proximal strat, tap technique, distal strat, T-stenting technique, and you can see in blue, both in T and tap, side branch stent position. Another case example, so 111 isolated, we wire first the most complex anatomy. After that, we predilate towards the most difficult branch, towards the circ because of the calcium. Inverted stenting again from the left main into the circ. Positioning in the cranial view to make sure that we cover the ostium and deploy stent. After that, pot with 5.0 balloon. In spider view, we check separation of the branches, we cross the most distal strat, and after that we do kissing. After kissing, we see haziness at the ostium of the LAD, so tap stenting again with precise coverage of the ostium of the LAD, inflation, kissing, and repot proximally, and final optimal angiographic result. We recommend IVUS and we really use frequently IVUS. This is another tap case, stable angina, normal LV function. In the cranial view, we see 111 stenosis of distal left main, spider view, and the cranial view, another lesion in the proximal LAD, normal right coronary artery. Strategy was to use IVUS in order to determine plaque composition and distribution at bifurcation site, but also to select the stent site and the landing zone. Our strategy was, according to evaluation, provisional left main LAD with stent optimization and IVUS. This is a baseline IVUS. There is a lesion calcified in the proximal LAD, and then we go now towards the left main. You see calcified lesion, eccentric plaque inside the left main, and the ostium of the left main is free of disease. So a lumen area, minimal lumen area inside the left main 4.5, in the proximal LAD 3.2, so we plan to predilate and then cover both lesions. Left main ostium was not covered intentionally, but we had at least 10 millimeters of stent inside the left main, resolute onyx 3.5 by 26. We post-dilated inside the proximal LAD because of that calcium. And then with NC, we perform short NC balloon 4.0 by 6. We perform pot inside the left main. And we see some pinching at the ostium of the circ, so you see ostial circumflex compromise, and we dilated and we performed final kissing, but result did not improve. So we shifted from provisional to tap stenting. You see position of the stent in the ostium of the circ with balloon inside the left main stent, non-inflated. We deployed the stent, did kissing balloon inflation, and after that we did final pot. But what I saw is that position of the pot was too distal, and you can see that tip of the balloon actually crushed the metal protruding from the top, metallic neocarina. And look, when we do control angio, we don't see that carina is crushed, but we intentionally did IVUS to confirm. And when you go inside the LAD, you see that first here stent inside the calcified lesion was not optimally opposed. So IVUS really helps to understand. and we also saw good expansion inside the left main. But then when we went, so the area was not adequate in the proximal LAD, then we went to the circ, and you see in the pullback going towards the ostium. At this point, what we saw is, you see here, metallic struts pushed by the final pot too distally, pushed to compromise the circ. This is what happened in the visible heart. If you have too distal position, when you do too distal pot, you will see now when you deflate balloon, you see that you shift the metal and you compromise the ostium of the side branch. So you have to redo kissing in order to reopen the side branch, and this is exactly what we did. Re-inflated and then repeated IVUS, and you see now it's going up towards the ostium, that we were able to improve the result. Was not really ideal, but we improved the result, and now area at the ostium was 7.1 millimeter, and we were happy with that result. So imaging really helps you when you feel difficulty or complication to understand and to open. DK crash has 7 steps, and it's important to understand that sequential crash is very important part of the new DK crash, and the first kissing should be done with proximal recrossing in order to remove the struts and not expand the gap. Final pot is also very important, and in DK crash, it's important that sequential crash, actually first balloon is sized according to distal reference, and then because you see that we don't completely crash, we need to take second balloon proximally and crash completely protruding metal, which will allow us really better performance of the further steps. After that, with first kissing, we go through the proximal cell, and with the proximal cell, we actually push some metal, and no gap at the carina level should be open. After the crash, main vessel stent is implanted, and then a pot should be performed in order to correct, and we again recross proximal or central, and then we perform second kissing and final pot. These steps I'll illustrate just with one very last example, courtesy of Professor Chen. Long diffuse disease in the circ, long diffuse disease, you see the difference between our case in the beginning and this one with such diffuse disease. Of course, two-stent strategy is better option. Predilectation and lesion assessment, lipid pool, and then positioning of the stent inside the circ, long stent to cover fully the disease, balloon part in the LAD, deployment of stent, and after that you see first sequential crash, first 3.5 by 12 balloon, and you see that you don't crash completely stent, so 4.0 was used, 12 in order to completely crash, proximal rewiring, first kiss, and then stenting of the LAD. After stenting, pot to optimize expansion, rewiring proximally, second kissing, and final pot, and the final result. I hope this was interesting enough to see how to do provisional, how to do DK crash in 2021, and I thank you very much for your attention.
Thank you very much, Dr. Stankovic. It was an excellent presentation, and it's given us a great insight into the distal left main bifurcation interventions and the techniques which can be used. And the session is open for comments. Any questions from anybody?
Yeah, first let us have comments from Dr. Matthew, and then we'll ask few questions.
Karan, it was a beautiful, very, very illustrative presentation. And thank you for presenting the latest information we have about your bifurcation club on left main bifurcation. study. Now, one question I have is, we do come across left main size bigger than 5 millimeters and 6 millimeters. Very often, we make a mistake by not doing a primary study before starting the case. You deploy the stent, then you want to get in and assess the vessel with an IVUS or OCT and find out the vessel size is bigger than 6. And you have already implanted a stent which can only expand up to 5.5. What do we do and what is the strategy then? And second, to start with, if a vessel we have assessed it's a 6 millimeters or plus, then what is the optimal stent to be taken? Do we have any stent ideal for that situation?
Yeah, thank you very much, Matthew. This is really, as usual, very appropriate question and very burning one. Second one, I think I can take easily because there are at least 2 platforms in the moment, Resolutonics and the new Synergy with the large size, which can be open up to 6 millimeters. So Resolutonics 4.5 and 5, you can deploy without deformation up to 6 millimeters. And this was confirmed in the bench as well as in patients with IVUS and OCT. For the first question, I really don't have perfect answer. What I usually do, you already angiographically see that vessel inside the left main vessel is very big. So I try to upsize the maximum stent diameter that I can use for the LAD deploy at a low pressure. For example, if it's 3.6, 3.7, maybe you can use 4.0 or 3.5 new Resolutonics. And that one deploy at nominal pressure, even low pressure at 6 atmospheres. And then pull it back and fully open because 3.5 new generation Onyx or Ultimaster or Synergy, you can open up to 5.8. Usually with some plaque existing inside the left main, you can come close to 6 millimeter that you mentioned. But as I said, in my practice, when I see such a large left main, I really try to use imaging to understand not only reference landing zones, but also to understand plaque distribution, vessel sizes in both directions, LAD and CIRC, and then select the most appropriate way to position the first stent and then optimize with POT as close as possible. Usually with some atherosclerosis spreading in that area, you are able to fix the stent at 5.8, 5.9.
Mahesh, can I ask one more clarification?
Yes, sir.
At the same line, what we have seen is a very disturbing situation. Most of the stents, especially the Medtronic stent, once you overexpand it to 5 or 6, 5 stent to even 6 millimeter size.
Yes.
The whole stent, when you look at it with the IVUS or OCT, it looks like a ring and no studs attached. It's entirely separated. There will be plenty of tissues protruding through that. Then would you recommend additional stent for the safety? Because we feel very uncomfortable to just leave strands of metal covering a big left main.
Yeah, I agree with you. This is what we usually do, another short stent inside in order to fully compress. And I remember, I think we should avoid thin strut stents for that kind of anatomy. I remember the time that Dr. Colombo was speaking about Cypher and 145 microns, which was really strong enough to completely cover left main and give enough radial strength and support to help keeping that vessel open. So we need stent inside the stent, but then probably something with thicker struts could be better solution. I remember that he liked BX velocity, and you remember he says you put drug-eluting stent inside and then another BX velocity to give architectural support. So if you select second one, probably something thicker if the tissue prolapse is so extensive. But as long as you have IVUS and you confirm that you embed metal inside, I think it's very, very important and much more important than to leave prolapsed tissue without second stent. So danger of having 2 layers of metal compared to tissue prolapse and frailty, I think it's better to have 2 layers of metal well opposed and embedded inside the left main.
In your practice, what is the percentage of left main, especially left main bifurcation, you get away with a single stent strategy? Because we unfortunately don't find that many patients in our practice which can qualify for a single stent strategy. Our count we did few years back, not recently, we had almost 75 to 80% were all adhering to stent strategy, because probably our patients are coming late. I don't know, others will have the same experience or different. They can also comment. And what would you do? What is the practice you see cases in Europe?
Yeah, look, I intentionally put this table comparing DK Crash 5 with DBC main, because in your area, prevalence of diabetes is more than double compared to European. In my country, prevalence of diabetes in patients in the cath lab, recently I calculated was only 16%, 1/6. So
this is more than 50%.
Yeah, in India, I know it's 45 to 50%. So this explains the pattern and distribution of diffuse disease and the popularity of 2-stent upfront stenting with 2-stent strategy in Asia overall, especially in India. I saw so many live transmissions with really diffuse disease, more than 16 millimeter, like in DK Crash 5. Anyway, as a philosophy, my strategy is slightly different. Stenting left main LAD, opening struts, and then doing T-tap or culotte, depending on the angle, is what is my practice for more than 25 years. I understand that with DK Crash, that you really beautifully perform, and you do it on a regular basis. So for you, those 7 steps are not so cumbersome as it is in my mind, because for me, if I do provisional, even if it's culotte in DK and DK Crash, in my mind, differ in the following. When I do DK Crash, I do really complex steps, recrossing, crushing, difficulty in recrossing, all the tips and tricks that you know very well already because of practice. If I do culotte is actually provisional in one direction, another provisional in another direction, you know. So you put stent, you do pot, you do kiss. So it's provisional towards the cert. Then I put stent in the LAD, I do pot, I do kiss. So for me, in my mind, I don't know if it's correct, but in my mind, it's one provisional and the other provisional, and this becomes double kissing culotte, which should have good results if side branch disease is not so diffuse. I don't know if side branch disease is really 20 millimeter, if culotte is comparable, but in Europe, we don't see those patients. I never saw patients of the DK Crash 5 study in European countries. Those patients usually go probably very rarely, they come and then we discuss whether or not it's surgery or PCI. For you, it's a regular everyday practice, and I fully understand that for you, DK Crash is a piece of cake because you do every day one DK Crash. So I fully understand philosophical approach of Asian compared to European population, but I think in US, they also have a lower rate of diabetes and more short disease in the side branch. So I think that this part of the world is more culotte, T or tap, and Asia is, because of diabetes, more DK Crash.
Yeah, Mahesh, can we ask questions?
Yes, one question.
Absolutely.
Yeah. See, basically, as Dr. Matthew very rightly said, in India, we go upfront bifurcation stent because patients are complex. And once we do a provisional, like what you said, and side branch is compromised, we lose out on decay cross, which is our favorite technique. So that is one reason why probably upfront we prefer decay cross rather than afterward, because I have seen some colleague doing internal cross. So what is
Yes.
your experience about internal cross? Because a lot of material remains projected inside.
Yeah.
So what do you think about that option?
Yeah. Thanks. When we wrote our consensus document and when we discussed internal decay crash, we looked in the literature and there are really only anecdotal published cases. So it's not so popular. So we practically excluded from the algorithm because it's not something that is regularly used. If you look the reports of John Ormiston, he says by internal decay, by internal crash, you actually cover the best from the perspective of bench testing. You cover ostium of the side branch much better than with regular decay crash starting from the side branch. But since it was not utilized, it was not tested in the study, it's just anecdotal images, we exclude it, although we accept possibility to do it if you wish.
And second thing, you said that the side branch length is very important. Why it is so important? If suppose patient has large side branch and there is a 90% lesion, but it's less than 5 millimeter, how does the length has importance or impact in decision making?
Yeah, thank you for that question. It's one of the key questions for provisional philosophy. If you have short lesion, it usually responds very well to kissing, predilatation of the side branch through the struts and kissing. And criteria in all the studies that we had so far, from non-left main, but also in the left main, criteria for second stent are tight lesion, more than 70% diameter, or decreased flow. After having dilatation with non-compliant balloons, so you have to be careful not to oversize. If you oversize, you dissect. But with short non-compliant balloon, don't extending too deep in the side branch, you usually achieve good angiographic result, and we try to avoid second stent if we have TIMI3 and residual stenosis below 70%. According to all the prior studies, this results in adequate clinical follow-up, so you don't increase complication rate. And that's why short versus diffuse makes a difference. In DK Crash 5, they had, I think, 5 or 6% that they had occlusion of the circ in provisional. But if you occlude, you need to put second stent. Of course, this extends the percentage of two-stent strategy in provisional if you have diffuse disease. In short lesions, you don't have such high rate of flow compromise, and that's why short versus long in meta-analysis was also confirmed as a factor to determine planned two stents versus planned provisional.
Hello.
Yes, yes, Purva.
Yeah, was sorry. Yeah.
Can
Yeah.
ask one question? Question?
Yes.
Hello.
Yes.
Yeah,
Purohit
for
ask-
Dr. Goran Stankovic. Sir, I have one question. As I understand, the decay crash gives excellent results as per the data.
Prakash, you are not audible. Apurva.
Understand.
Yeah. Prakash, you are not audible.
Okay, I'll go ahead with my question.
Yeah, go ahead.
Please.
Suppose there is a circumflex 2.75 to 3 mm visually, and there is a less than 10 millimeter.
Prakash, you can take the question later on. Apurva is asking question.
Yeah, so there is a less than 10 millimeter side branch lesion at the circ with around say 60 to 70%, and it is around 2.75 to 3 mm branch. When you start with the provisional technique, what is the size of the balloon you use for predilatation of the circumflex?
Yeah, thank you.
Technique
Prakash,
that you are able to perform kissing balloon final dilation of all the vision. If you get technique,
Prakash, you can be mute for time being. Apurva is asking question.
What sort of
Yeah.
if
So
I perform bifurcation using
yeah.
mimic technique, I extend the result with the similar technique.
So
Can you hear me? Am I audible?
Prakash, you wait for 2 minutes. Apurva is asking question. Once he finishes the question, you can ask.
yeah. So
Yeah.
to ask
So-
first question about predilatation of the side branch.
Right.
Unless it's diffuse disease and calcified, we don't predilate the side branch.
Right.
We
Okay.
predilate, yeah, after stenting we predilate, because when you don't predilate in advance, a remaining channel after stenting of the main vessel is actually the only space for your wire to recross. So any cell that you are recrossing becomes carina cell. You are much higher likelihood not to dissect by predilatation. If you dissect with predilatation, mechanism of dilatation is creation of dissection. So even if it's not compromising the flow, inside the vessel wall, you have layers of dissection planes. So after recrossing following stenting, your wire has very high likelihood of entering in one of dissection planes and extend that dissection. So first, we don't routinely predilate. If we predilate, we undersize. So we predilate with the undersized balloon, and I try to predilate if possible with non-compliant in order to control the diameter. By increasing the pressure, I try not to increase too much the diameter of the balloon. So I don't say we are not afraid. You know, the main psychological difference is fear of losing the side branch is a major reason for stenting the side branch first.
Right.
I know that if I have two wires in place, I can always, because of the fractal geometry, after stenting of the main vessel, if I compromise the side branch, I always have some space behind the stent in the main vessel, inside the left main, to go with 1.1 balloon or 1.0 outside on the jailed wire to reestablish flow in the circ. So I don't have really a fear before doing high pressure dilatation in the pot area. I don't have fear of losing the circ. I know I can always, with new generation short balloons, go behind and reestablish flow in the circ and then redo recrossing. So I think that provisional gives you that option to make yourself comfortable by stenting main vessel, as long as you have wire in the circumflex without predilatation of the circumflex.
Right.
I don't know if this answers your question.
Another short question. When you are doing a provisional and you land up with a tap or T,
Yes.
recently I experienced that when I was trying to do the tap, the stent jumped in and I had to convert to mini culotte. So what is your precautions for this, to prevent this kind of thing? This is a question to Dr. Matthew also, if you can.
But yeah, to be honest, between T-tap and mini culotte, I don't have any psychological difference. As long as you make sure that you have full coverage of the ostium. If it's tap, I prefer to have, instead of long tap, I prefer to have mini culotte. So I try to limit free floating metal. I don't like to have a long metallic neocarina in tap. So if angle is relatively narrow in the distal left main, I would prefer mini culotte instead of having tap with long metallic neocarina. And there is no difference between T-tap and mini culotte. It's just how much you pull back your stent from the circ. And
right.
It's important that you fully oppose and you use imaging to make sure that it's well deployed and that you have no malposition. So no difference psychologically between these three. Any is acceptable.
Thank you.
Prakash, if you want to ask one question.
Yes. I have one question. is there any advantage of decay crush technique or mini crush technique? Because as I understand, the advantage of decay crush technique is that you are able to do the final kissing balloon infection in almost all the patients because of first kissing balloon infection. While in mini crush, sometimes it is difficult to recross and difficult to achieve the final kissing balloon infection in all the patients. So if I can achieve final balloon inflation in mini crush technique, can we accept the result will be similar to decay crush technique?
Yeah, thank you for that question. What we learned in the beginning, I was working in Milano with Dr. Colombo when he actually developed crush stenting technique. And he wanted to make sure that he covers the ostium. That's why he pulled back stent from the side branch and crushed it in the long segment. And he was frequently not able in the beginning to recross. But what we saw is much higher restenosis rate, and in some cases we had also myocardial infarction in the follow-up. That's why in two-stent technique, especially in crush, decay crush has the advantage because, as you said, with the first kissing, you limit the amount of metal in the ostium of the circ, and when you implant stent in the left main, you have actually only one layer of metal to recross. With mini protrusion, 2 to 3 millimeter protrusion inside the left main, and adequately done first kissing, I think this is part of the explanation for reduction in events. And I believe that if you speak about crush, double kissing crush really has clear documented advantage compared to any other form of crush. And I remember a long time ago, there were 18 different variations on how to do crush in the literature. So I think that refinement with sequential kissing, with sequential crush, to make sure that you fully crush stent inside the left main really gives you much easier procedure with much less metal to recross. And decay crush, if crush is the selection, it should be decay crush and not the other variations of crush.
Just to answer Dr. Apurva Vasavada's question, if when you are expanding the side branch stent in case of a T-stenting or any technique where there is a provisional stent, we have to cross over. His question was, what I understood was, while deploying the stent loses its position and goes down and doesn't cover the ostium. Is it right?
Yeah, if that is the question.
Or the other way around, it came into the left main. That's what happened.
Yeah, but see, Apurva, the thing is, there are three possibilities. One is T-tap, second is T-tap and protrusion, third is culotte, but something in between the two. It's neither mini culotte nor tap, means it's a hanging in between, not touching the opposite wall of the left main.
Yeah,
then what would you do? That is the worst problem.
That's why I asked.
Yeah, that is an internal crush is the only problem.
You find the stent moves forward, there is very definite methods to prevent that missing the ostium. One is do not give the inflation device your assistant or the nurse to inflate.
Yeah, that's one. Yes, certainly.
That is the main cause, because they don't have any finesse in opening the balloon. When you open the balloon very fast, the balloon tend to move downwards and you miss the ostium. Don't allow that. Preferably you should allow a small, yourself dilated, 2 atmospheres, 3 atmospheres, take time, slowly inflate it. The chances of missing the ostium is very less. Second, the drag on the balloon shaft while going up on the balloon, that will also prevent from the balloon and the stent shifting downwards.
Right.
Can we reposition it if it is 1 or 2 millimeter inflation? Up to what level you can reposition? Suppose you feel you are not comfortable. Up to 1 or 2 millimeter?
It's very difficult.
Yeah, I know. Just
we have not tried it. So technically it's going to be difficult because
I agree. Balloon can come out.
The stent is also expanded. The friction from that metal to the other metal is going to be high. Your chance of losing the stent position is higher.
I
Okay,
would
it's-
deploy, yeah, I would certainly deploy and then try to correct with another stent depending where
Right.
As Dr. Matthews, one of the people in our Indian EB club says you should always keep balloon in a main vessel and inflate it, and then you do the T-tap. So it will never ever get converted to not that
yeah,
way.
yeah,
You
so
should never do that. I think Gaurav is also saying that.
yeah, no,
Because what happens is when you have an inflated balloon in the main vessel, then while inflating the side branch balloon, the balloon part which is beyond
Yeah, stand.
will push the stent forward. Don't do that
Okay,
at all.
okay.
It's dangerous. That's what I feel.
No, I agree. You lose osteal miss.
yeah, there was from Austria even series of cases with a smaller size balloon inflated inside the main vessel, but as Dr. Matthews said, you really miss the ostium because as soon as you start inflating, you push and you miss the ostium and you have a twisting of two balloons.
And
So
if you have smaller size balloon, it might slip to the side because it's not a round thing.
Exactly, yes.
That's an excellent interaction. Thank you, Dr. Stankovic. This was wonderful, and thanks to the panel also. It was a good interaction. Yes. We'll move on with our next talk. That's by Dr. Samuel Matthews. He'll be talking on my approach to left main bifurcation PCI. Dr. Matthews needs no introduction.
Yeah, I'm just trying to.
Yes, sir. Yeah. Dr. Matthews has pioneered angioplasty in India, and he is the guru of this generation of interventional cardiologists in India. He's trained numerous interventional cardiologists in India and overseas. He's the investigator for numerous device trials, research programs. He's the faculty at numerous national and international workshops and conferences. He's been the recipient of many prestigious awards. To name a few, he's the recipient of the Padma Shri, Dr. B.C. Roy Award, the Lifetime Achievement Award from the President, the Doctor of Science Award from the Dr. MGR Medical University, and the list goes on. So, Dr. Samuel Matthews, I welcome you and I request you for your talks.
Thank you so much. Am I audible?
Yes, sir. Yes. And slides also seen, sir.
Okay, thank you. Thank you, Gaurav. You have been able to come live through the modern technology, which is putting us all different positions and able to exchange ideas much faster than otherwise. And thank you for being here. And on behalf of all my colleagues and Indian interventionists, we appreciate your participation. I'm extremely thankful to Baroda Heart Institute colleagues for inviting me to address you. And now that we have listened to Gaurav, let me show you some difficulties what we face in our practical life and the type of cases we deal with. Of course, Gaurav knows quite a bit about it, but let me clarify some of the issues. This is something which all of you know, the shear force and what it implies onto the vessel wall and what is the technique to be used to avoid or reduce restenosis. All of you know, you have seen these slides. Basic decision making starts, as Gaurav said, starts from the clinical characteristics. Everything matters. Diabetes, of course, is a major issue. Other diseases, LV function, all those things has to be considered when you are making a decision to approach a left main bifurcation. The patient and the angiographic characteristics, how it involves, if there is calcium, if the length of the lesion is more distal lesions, we may be able to fix the bifurcation or left main clearly, but if there is no distal flow or reduced distal flow, then you are in for trouble. And because that blood flow and turbulence caused because of the reduced flow due to the distal disease is going to be the reason to the stent to close and very complications related to that. And I firmly believe when you are attempting a left main bifurcation, you have to have a complete revascularization. And incomplete revascularization is not going to be satisfactory at all. And also we have to look at the number of stents and overlapping and other complications and complexities of the case. Any stent, we have to be very careful with the deployment. This we have been emphasizing at all meetings, and we have been addressing that all the time. We have to get optimized stent deployment. That is an absolute must when we deal with the left main bifurcation. Whether you use OCT or IVUS, there is some controversy, but at least one imaging modality which you are very familiar with is a must. This has to be the ending point for any bifurcation when you are dealing with especially left main. We have seen from all the data which is available that Syndex trial suggested that DS may be acceptable option for patients with left main with low or moderate coronary artery disease. But there is enough of controversies which has come subsequently when we started looking at more randomized trials subsequently. Excel trial said, proved that similar rate of clinically meaningful composite outcome of death or MI in 5 years when compared with surgery. But when we came to Nobel, there is a definite difference between PCI versus CABG. This is all known to all of you. So at present, PCI remains inferior to CABG in 5-year MACE. CABG was superior to PCI, also in the group of Syndex score, low Syndex or medium Syndex score. All-cause mortality was similar for PCI. Look at some of the cases what we practice. I have avoided taking you through the theory part of the left main bifurcation because that is well known to all of you. This is a clear-cut case of by ostium of circumflex as well, a lady being deceased. We decided to go straight for a two-stent strategy because both were deceased, and we used a 3.5 millimeter stent in the LAD and a 3 millimeter stent in the circumflex. This is the 9-month follow-up of the same patient. There is another patient who had severe diffuse disease of all the coronary arteries, a diabetic patient, but not accepting surgery as an option at all because of various comorbidity the patient has. You can see that the LAD is occluded after the diagonal, the circumflex, the OM is occluded, multiple occlusions. If we have to treat the ostium of the ramus and circumflex as well as the LAD, we have to get all the distal vessels open first. First, we got across through the LAD at the diagonal level, and then sequentially dilated each vessel, and finally this was the result. I just want to re-emphasize the same point that when we deal with multivessel disease, the distal flow is extremely important if you want to keep that stent open in the ostium of the LAD and the left main. This is the 9-month follow-up of the same patient. I'll take you back a little earlier. This is a patient which I treated in 2001. Severe disease. The LAD was diffusely diseased. Proximal segment is calcific. The circumflex is also diseased. The surgeon initially agreed for surgery, but later he refused surgery because he said I don't have any place to put a decent graft to the LED. The OM was graftable. Finally, we decided to take her up for intervention. We used cutting balloon those days. That was one of the devices which we used for very diffuse disease, and results were satisfactory. We used a cutting balloon in the circumflex, then took a rod ablator for the LAD, proximal to the distal end, ablated it fully. This was 1.5 millimeter bar. We got a decent flow. Distal vessel was looking better than what it was. So we decided that probably we will only treat the proximal LAD and not the distal LAD, because the flow was impeded because of the proximal disease, so we decided to stent only from the mid segment backwards and decide whether to stent distally if the flow is not optimal. And the proximal stent. And so we put two stents, one from the left main to the middle LAD, as well as another stent in the circumflex. The circumflex was, as I told you earlier, treated with a cutting balloon and then a 18 millimeter stent used in the circumflex. Quite satisfactory. We left it at that. We finally convinced the patient to come back for a restudy, see the result, what's happening. The patient, of course, cooperated, kept the diabetes under control, and lipid-lowering agents were very prompt, appropriately taken. Look at the whole vessel has changed. The LAD as well as the circumflex look much better than what it was post-plasty. This is a 3-year-old follow-up angiogram. When we deal with the patients like this, I don't think there is any role for approachable stenting in this case. You have got dense calcification of the distal left main. You see it in this frame. Severe calcification and very little space for the vessel to even wire it. We wired the circumflex first and rotablated the circumflex. We know that LAD is a more important vessel, but if you look at the angiogram carefully, we felt we will be able to get an access for the circumflex post rota of the circ, which we did, and this was the final result we got. This is a case that most of you would have seen during India Live 2014. Elderly lady, 81 years old, unstable angina, very sick with osteodisease of the circ as well as a dominant circumflex with a thrombus sticking after the first oil. We took her up. This was one of the live cases. First ablated the LAD, then the circ, and opened up the proximal segment. And we purposely avoided the circ distally, only put a stent there because we could see the thrombus sitting there. We went only direct stenting, and we achieved a final result of very satisfactory result for the LAD and circumflex. This is one of my patients, came from your city, Baroda, a doctor's father with severe disease, unstable angina. He was immunocompromised, calcific left main, LAD, circumflex, everything calcified, and cirrhotic too. We have no choice other than to accept him as a patient. IVUS could not cross the lesion at the bifurcation of the left main. Then we went ahead sequentially, rotablated all the 3 vessels, and we used 2 guiding catheters to position 3 balloons and stents together. 4 millimeter and 2.5, and with a very satisfactory result. There's another lady with on prednisolone for long-term ILD. We can see the significant disease of the circumflex, the ostium as well as the LAD, which rotablated with a 1.5 bar in the circumflex, followed up with a 3.5 and 3 millimeter balloons, and we didn't get an optimal dilatation. This is actually the second kissing balloon was after using a cutting balloon. Open it up and the stented, and subsequent picture shows, sorry, I think you can see carefully here. See, already you can see a perforation here at the distal left knee. What can you do for that? If you put a covered stent there, that is going to block off the LAD. But we thought of changing the strategy, put a balloon, the stent balloon was positioned in the LAD, and then put a covered stent compressing onto the stent balloon, which kept the lumen open, which you can see very clearly now. The tip of the proximal part of the stent you can see, and allowing the LAD flow, and patency was maintained. This is probably, I think, my last case. This is a patient who had an intervention with one of our colleagues, an isolated circumflex lesion, absolutely isolated. The LAD was clean, left main was clean. So the decision was in favor of putting a single stent in the left main. Stent was put, very satisfactory result in the circumflex. The branches, all the branches are open, only single stent. 3 years later, patient came back with significant symptoms, and the angiogram showed restenosis in the circumflex, as well as there is a lesion in the ostium of the distal part of the left main. So what are the options? We have decided to re-intervene because patient wanted early an intervention, not a surgery, only willing for surgery if intervention is not possible. We looked at the IVUS, you can see this now. What had happened is, it's an under expanded stent, what was the cause of the instant restenosis. You can see the instant restenosis in the ostium of the circumflex. More than the instant restenosis, it's a compression, it's the under expanded stent which was giving us a problem. So we decided to predilate and then use a cutting balloon to open up the circumflex well. So at 3 wires, 4 wires, 3 wires. Yeah, LAD posterior circumflex as well as the main circumflex. Our decision was to only dilate the posterior circumflex artery because very short lesion that opened up quite well, and we intended to stent only the main circumflex across the side branch. If you look at here carefully, the OM1 also has got another lesion. Then beyond the posterior circumflex, there is another lesion as well as the LAD, which has to be treated along with the left main. So sequentially dilated it. We knew that if we have to treat the OM1, we have to treat it up front. So we predilate that. And second is I can see it here. Okay. Dilate with kissing balloon, followed by stenting of the circumflex alone. We decided to do a mini crush. You can see the stent is close to the left main circosteum, distal left main. The reason behind doing this first, because once you have a stent in the circumflex, it will be very difficult to take a 90-degree bend with a long stent into the OM1. So once the OM1 stent is positioned correctly, you will find it difficult to get the second stent into the circumflex, and because of the wire bias, the stent will selectively be rubbing against the other stent. So we decided to position both together, deployed only the circumflex OM stent, and kept the circumflex stent like that, because we have to get next stent for the LED left main also ready at the time of deploying the circumflex stent. This is also a mini crush, which we did after positioning the left main and LED stent. Deployed the LED stent properly after withdrawing the balloon from the circ. And as Goran said, it is hot. We want to have absolutely proper dilatation of the vessel. Sometimes the stent boost helps, and followed by we did an IVUS. IVUS was satisfactory. We decided to approach the posterior circumflex because that was also diseased. We could have left it alone, or at that time we were excited with our result, said, okay, we will do this also. And it was, did a kissing balloon, final pot. Okay, this is a very gratifying result we had. Sorry, I think I went a little too fast for the system to catch up with me. Okay, we got a very good result. We followed up that patient very meticulously. Okay, sorry. Anyway, the 18-month follow-up showed that all the stents were absolutely normal. Now, what is the take-home message from all what I've been discussing or showing? We had a full scientific coverage from Goran. I understood that any complex case can be treated if you logically think and evolve your strategy correctly. Break down the multiple bifurcations and other complexities which is following independently and try to treat them separately, keeping in mind that what is coming next, and you leave the way for that also. Reconstruct the entire sequence of the procedure in your mind meticulously and follow the sequence to attain the end result. Liberal use of rotablator, cutting balloon, angiosculpt, and other devices will significantly improve your long term. These all left main cases also belong to a chip. I firmly believe no. Hemodynamic support is needed only if in hemodynamically unstable patients. It is not related to the procedure. Today, with the newer devices and experience of the operator, the time of left main getting occluded is very short. Most of the patients will be able to tolerate that, provided you know what you're doing. Less than 1% will need LV assist device or ECMO or Impella. This will only to tide over the hemodynamic instability. LV assist devices may be an expensive luxury, but if you can have it, it's well and good. Perfect technique and perfect end result should be the key to success. And thank you very much for the patient listening.
Thank you very much, Dr. Matthews. This was an excellent presentation. We saw a lot of cases with a lot of newer devices were used, and some of the cases were extremely complex. I think not many of us even would probably attempt such cases. This was excellent. Any questions from the panel? Any comments?
Yeah, can I have a few questions?
Yes, sir.
Yeah, see, we are lucky that we don't have Matthew here. Otherwise, our surgeon would die hungry. That is very clear things. Now, see, in Matthew, I asked one question to you that in one case you showed cutting balloon as well as non-compliant balloon dilated together as a kissing. So, would the cutting balloon damage the non-compliant balloon if you dilate them together?
I mean, you would have understood because of my my explanation not being very correct. I was trying to be fast to push on complete the lecture as early as possible. I must explain in such a way so this question came up. Never. When you are cutting balloon, you should never use another device on the side because it can damage the other device. Because cutting balloon, the blade is much sharper than actually you use otherwise. So you should never try and do that. We will never use it.
And if there's a big size discrepancy, as it was mentioned by Goran in previous case, like LED is a 3 and left main is 5, and so you can't put a stent from left main to LED. So in that case, you put much larger stent according to left main diameter rather than LED diameter. And can you always under deploy? Because I had impression that you should always deploy stent at nominal pressure. But I heard from your lecture or Goran's lecture that you can deploy 2 or 3 atmosphere. So how much is minimum atmosphere allowed to deploy the stent?
No, it is not that. Goran will answer his philosophy. My philosophy is you should have a stent. If we are dealing with the left main disease, left main, and you intend doing a stenting of the left main also, and that is a big left main, 5 millimeters or 6 millimeters. You have to have a stent which can go up to 5 or 6 millimeters. So you may be able to deploy the distal part of the stent at 4 or 5 or 6 atmosphere. You watch the distal balloon. If the balloon is expanding only at the distal tip of the stent, that is the distal end of the stent, that is little dangerous. You have to be careful. Don't try to go up too much and deploy it only as soon as the balloon is free to move inside the vessel. You can take it out and put a shorter balloon and optimal sized balloon and deploy that stent part. Then take a short high pressure balloon which is optimal size and deploy it. That can be done very safely. Rather than trying to use a balloon which is equal, or as you asked the same question, trying to deploy a small stent and then trying to expand it to a bigger stent, that will completely deform the stent structure, and which may not be the optimal thing to do. I generally do it at a low pressure, maybe 5 or 6, post-dilated with an optimal size balloon. Goran?
Thank you, Dr. Matthews. This was excellent. And we now move on to our next talk, that's by Dr. Ankush Gupta. He is an interventional cardiologist at the Military Hospital, Jaipur. He has a fantastic experience in coronary diagnostics, imaging, and interventions. And he's been involved in many national and international trials and research. Dr. Ankush Gupta will be talking on imaging-guided approach to left main bifurcation, PCIs. Yes, Dr. Ankush Gupta, we are ready for
Dr. Matthews, I think your screen is being shared. So you can just go to the share screen and stop sharing.
Yeah, I think Dr. Matthew has to unshare his screen first.
Dr. Matthews, sir.
I'm trying to do, what should I do? You can tell me what.
You can go to share screen and stop sharing the screen. In the bottom, there is a share screen.
Okay. Am I gone?
No, sir. Okay, sir. Okay, yes, sir. Yes, sir. Good, sir. Okay, thank you, sir.
Thank you.
Ankush.
Yes, sir. I'm trying to share my screen.
Yeah, fine. Now you're very well visible.
You
The slides also are seen now.
okay.
Okay, great.
First of all, thank you, Dr. Matthews, for excellent cases that were really complex. And thank you, Dr. Mahesh and Pravinder, for inviting me for this talk. I'll be mainly focusing on OCT-guided left main bifurcation angioplasty. As you all know, left main supplies around 70 to 100% of LV myocardium, depending upon its dominance. So whenever we are dealing with left main intervention, you have to be very cautious. Either you have to have a experience like Dr. Matthew, or you have to have some, imaging modality, either in the form of IVUS or OCT, so that you get to know what are you dealing with, and you know how to deal with that particular lesion morphology and angles of left main bifurcation. IVUS has got its own advantage of that it can image large vessels. It doesn't require contrast. And on the other hand, OCT has got an advantage of better resolution, much better resolution as compared to IVUS, number one. And it has got a better imaging of the calcified lesion. It can image the calcium very well as compared to IVUS. It can tell us the depth of the calcium, extent of the calcium, and we can choose our lesion modification device accordingly. And another advantage of IVUS is that we can it can image the ostium very well. Whenever we are dealing with the left main ostium, IVUS is the preferred modality for imaging. Left main bifurcation angioplasty is different from other bifurcation because of the angle, because of the discrepancy between the main branch, proximal and distal to the side branch, that is LCX. Left main is more prone to be having a calcified lesion, and the side branch in case of left main bifurcation is not usually small. It's either it's a non-dominant significant LCX, or it's a dominant LCX. So what we can look for in OCT during left main intervention, pre-PCI OCT image, the most important thing that we should get to know is lesion morphology. Whether this is a lipid-rich lesion, or it's a fibrotic lesion, or it's a heavily calcified lesion, so that we get to know what is the device that is required for lesion modification. And we can very well assess the lesion length by choosing our proximal and distal landing zone. And one of the key factors while dealing with left main bifurcation angioplasty is to choose the length. Proximal part of the stent should be at least 8 to 10 mm from the carina of the bifurcation, and we can very well see the proximal and distal reference diameter. Proximal reference diameter is required for pot balloon, that is the left main, which we can accurately assess the size of left main, and we can choose our pot balloon size. And distal reference diameter is the diameter that is required for sizing of left main to LAD or the LCX stent. During PCI, if we have got an angiocore registration, we can accurately place our device during angioplasty. And during PCI, when we have done our main branch stent deployment, 3D reconstruction help us to assess our side branch guide or recrossing, whether we are recrossing from the proximal stent studs or from the distal stent studs. And post PCI, we have to assess the stent apposition, stent expansion, significant dissection at the proximal or the distal edge, geographical miss, or the plaque prolapse. The most important part in post PCI is stent expansion, because that is related to short and long term outcome. And the post PCI, if you are dealing with two stent strategy, 3D reconstruction is very important. Now I will take you to the few cases and we see how we can use OCT for left main bifurcation angioplasty. So this was a 50-year-old female. She came with an NSTEMI. As you can see, the patient had a significant left main bifurcation lesion. 2D echo showed 45% ejection fraction with the severe LAD territory hypokinesia. As you can see, there was a left main bifurcation lesion with Medina class 111. As Goran recently said, that LCX ostium is disease, seems to be disease, but it's not. It's less than 10 or it's less than 5. He may go for single stent strategy or provisional strategy. In this case, we thought that we may go for a front 2 stent strategy, but before that, when we imaged the vessel, this was the run when we took it from the left main to LAD. Now this is the left main, this is the origin of the LCX, and this is the LAD. So with pre-PCI OCT during left main bifurcation, we came to know that this is a fibrofatty lesion, and you know your modification device. So you need a semi-compliant balloon for this modification of this kind of lesion. You know your landing zone. It was the size of the landing place was around 3.25 from lumen to lumen, and the left main was of around 4.5 mm. So we know the size of our pot. We know the size of our stent. It will be 3.5, and we know the length of the lesion, and it came out to be 33. And as I just said, when you are placing measuring the length of your stent, it has to be at least 8 to 10 mm from this carinal tip, so that you can have a easily 8 mm or 10 mm balloon for pot. Another thing that we look for in case of left main bifurcation angioplasty is carinal tip angle and distance from carinal tip to bifurcation point. One of the study that was done by Watanabe that showed that if we have got a carinal tip angle less than 50 and carinal tip to bifurcation CT BP length less than 1.7, the chances of losing side branch is more. So in this particular case, when we did the LCX run, the LCX ostium was around 60% disease. When we measured the CT angle, it was around 65 to 70, and CT BP length was 2. So we changed our strategy after this imaging. We thought that let us go ahead with the provisional strategy, and then we placed a stent 3.533 from left main to LAD. This was the final result after pot with the 4.510 NC balloon. You can see the T3 flow in the LCX. Hardly there is any significant stenosis at the site of LCX ostium, and you can see even this OM, early OM is also flowing very well, and acceptable result. Then we did a post-PCI left main to LAD run. In post-PCI left main bifurcation angioplasty, you have to look for the distal as well as proximal edge, whether there is any significant dissection. The definition of significant dissection is either it is extending up to the media, compromising the flow, or it is more than 60 degree of angle and the length is more than 3 mm. If you have got a dissection with the 60 degree extending up to 60 degree angle and the length is 3 mm, then you have to address it. And second thing, you have to look for the apposition in post PCI rendered stent view. This is the apposition indicator in which we, if it is wide, you know the stent is well apposed. And in a present OCT softwares, you get to it automatically calculates the stent expansion. One of the very important factor one has to be careful during seeing this expansion is that as you all know, left main size is different from that of proximal LAD, from that of mid LAD. So whenever we are calculating, seeing the expansion of the stent, it has to be stepwise. We have to first see the expansion of the left main, then have to the proximal LAD, then have to this mid LAD, because this software actually calculate the expansion according to proximal and distal reference diameter. Another thing that that is peculiar when you are dealing with the left main bifurcation, when now in this particular case we have placed a stent from left main to LAD, we have done the pot, And after we have done POT, then we reconstructed, 3D reconstruction shows that this is the side branch ostium. In this side branch ostium, you can see this is the carina, this is the L6, and this is the LAD. There is no link at this that is connected with carina. So this is a link-free carina. And yeah, as you can see, there is only 1.5 stent struts. One of the study that was done by Okumura, prospective study, they showed that if you have got this kind of side branch ostium after main branch stent placement, and if you are able to cross distally, which you can do it very well with 3D reconstruction, so the chances of inappropriate stent apposition at side branch is very less as compared to if you have a connecting. So the study that was done by Okumura, they divided their population. It was around 100 patients. They divided into link-free type, this type of side branch ostium, and the distal crossing, that is LFD group, in which they saw that if you have got a link-free carina and side branch ostium and you can cross distally, the chances of inappropriate stent is very less, significantly less as compared to other group. And they also found that there was non-significant tendency toward lower side branch restenosis. And at 9-month follow-up, the event rate was not significantly different. There was no effect on the event rate in patients having link-free side branch ostium with distal recrossing. But they advise that large studies are required to look for this kind of implication. So when we are doing provisional stent strategy, we have placed a stent from left main to LAD. It's always better to look for the side branch ostium. If you are going for a kissing balloon inflation, you recross the side branch through the distal stent strut, and that can be confirmed with the 3D reconstruction. So what is the advantage of going from the distal stent struts? The advantage is that when you do a kissing balloon inflation, you will push these stent struts towards the side branch or opposite wall of the side branch ostium. So you will have a minimum carina, you will have a large orifice of the side branch ostium as compared if you cross proximally. So you will have a less metallic carina, large ostium, and better flow as compared to if you cross proximally. That is the logic behind going distally in case of provisional stent strategy if you are going for a kissing balloon dilatation. So this is the second case. He was 80-year-old male, a known case of interstitial lung disease on oxygen therapy. He came to us with the NSTEMI. As you can appreciate, there's significant lesion in the LAD. L6 was non-dominant, RC was normal, L6 was CTO, and we wanted to make it simple. But there was a early diagonal that was coming close to the origin of LAD, and there was significant lesion at mid LAD also. Then when we did the OCT, we found that there was significant amount of calcium here in the mid LAD. So again, we have to look for the morphology here. The morphology is the calcium. The calcium depth was more than 0.5 mm. The length was more than 5 mm, and arc was present. So this is the kind of calcium that needs modification. And when we saw the angle at the CT angle, it was 65. CT BP length was 2.1. That make us confident. Let us go ahead with the provisional stent strategy. In this particular case, the left main also the calcium nodule was present. In this particular case, we went ahead with the rotational atherectomy with the 1.75 per, and then we placed a stent, one from left main to LAD and another from mid LAD, proximal to mid LAD, and this was the run. And you can see again, after stent placement, you have to look at the distal edge. There was no dissection. The proximal edge, there was no dissection. And you have to look at the expansion. Now, in this particular, as I was saying, in this case, we have chosen this part from left main to proximal LAD. The stent expansion is 98%. When we did the 3D reconstruction, we came to know there is hardly one stent strut across the LAD diagonal bifurcation. So this is the kind of, I am not a great fan of routine kissing balloon dilatation. So again, I left it this case at this point, and this it's 3 years down the line, patient is doing absolutely fine. And this was the final result. So in this complicated case, 80-year-old interstitial lung disease on oxygen therapy, we made it very simple, and imaging helped us to know, okay, what kind of lesion we are dealing with. It was calcified lesion. We chose our modification strategy, and it was a simple. So this was another case. This was a 50-year-old male who came to us with the Crescendo Angina. As you know, this was significant left main bifurcation disease and mid-LAD CTO. RC was dominant and it was normal. As you know, this was a mid-LAD CTO. The length was around 20 mm. So we went ahead with the retrograde approach, and we opened this mid-LAD CTO with the reverse card technique. And finally, we placed the stent in mid-LAD. So this was the angiography after opening the mid-LAD stent. So now you can see the complex left main bifurcation lesion. There is tight lesion at L6OM also. Distal left main is disease, mid-LAD is mid left main is disease, and ostial LAD is also disease. In this particular case, when we did imaging, we came to know, again, the first thing is morphology. It was a fibrotic lesion. So we know that the device that may require is non-compliant balloon. Distal reference diameter was 3.5. Left main was of around 4.41. Again, the fibrotic lesion. So we modified this left main with a 315 non-compliant balloon. This was after modification. This was the dissection, and then we did a DK crush. First, we pre-dilated the LCX. Then we placed a stent, then pre-dilated with the same balloon ostial LCX. Then we placed a stent in the left LCX to OM. Then we placed another stent in the ostial LCX by keeping a balloon in the left main to LAD, non-compliant balloon. Then we inflated the stent with minimal perfusion. Then we took out this wire and balloon, crushed this stent with the balloon, then recrossed this LCX, and then did the first kissing. Most important thing in this particular case is that whenever we are going for the first recrossing in DK crush, it has to be proximal, so that we should not lose at the carina, the ostium of the ostium of the side branch. If we cross distally, we will push whole of the proximal part of the stent towards this side, and we lose the stent over the carina. So then we placed a 3.5 26 stent from left ostial left main to LAD, inflated. Then we did pot with the 4.5 10 balloon, ostial flaring, second kissing, and then repot. And this was the final result. So this was the final result, and epicaudal view, this is an alveocaudal view. You can appreciate that diagonal is flowing well. So when we took LCX run, again, post PCI side branch run, the distal, there was no edge dissection. It was well opposed stent, and the expansion was good. Then we went ahead with the left main to LAD run. The stent was well opposed. The expansion was good. There was no distal edge dissection, and the apposition, there was no geographical miss, and there was no significant prolapse. And you can see the opening of the diagonal and the opening of the L6. Now this patient came to us again after 9 months with angina on exertion. So this was in the April 2018. This was after 9 months. Now this patient has got a L6 ostial restenosis. Okay, so then we analyzed, let us see what happened when we first did this case. So when we first did this case, as you can appreciate, so this was the LAD, this was the overlap segment, this was the opening of the diagonal, and this was the opening of the LCX. As you can appreciate, this is the LAD and L6. There is stents hanging throughout the figure of 8. And when we analyze the 3D reconstruction of when we did it in the April, there was a large amount of stent studs hanging. So as this was a two-stent strategy with DK crush technique, this is not acceptable. You cannot leave this the side branch ostium at this. And let me tell you, we did final kissing, and this side branch with large amount of stent studs and 9 months. Just see what happened. All these stent studs now they are covered with and there is hardly any ostium left. So this was the reason of instant restenosis. So whenever we are doing two stent strategy, either DK crush or whatever, it has to be free of stent studs. So then we did few more cases, and then we started doing 3D reconstruction. This was another case in which we did a left main bifurcation angioplasty with DK crush technique. This was the final kissing. This was the final result. As you can appreciate, now at this point, once you have done a bifurcation angioplasty with two stent strategy, it's very crucial to analyze the side branch ostium while taking run from the main branch. As you can appreciate, there is a large amount of stent studs that are hanging on the ostium of the side branch. This you can appreciate both in the fly-through view as well as in the two cross-sectional view. You just see this. These are the stent studs that are hanging. Whenever the LCX opening is coming, throughout that LCX opening, this is the stent studs. So when we measured this, the CTBP length was 2.4, and the new metallic carina that we have left was 2 mm. So we have given a 83% iatrogenic stenosis. Just see. So after second kissing of DK crush, this is the amount of metal that we are leaving at side branch ostium. This made us realize. So we thought again and again, what is happening? What is the reason of having this much amount of carina even after second kissing? There are three possibilities. One, too much proximal recrossing during final kissing, number one. Undersizing of the side branch balloon for final kissing, and absence of sequential dilatation. As you can appreciate that there is hardly any opening, and mind you, this is the final run. So again, we should not leave at this point. In stent only view, you can appreciate that the wire is crossing very proximally, and there is large amount of stent studs are hanging. So the possibilities of having this amount of stent studies, absence of sequential dilatation, proximal recrossing, and undersized balloon. As we are doing a image guided OCT guide, we are choosing the size of side branch according to that side branch, and we are doing proximal crossing. So this is another case in which we did left main bifurcation angioplasty, and this is the final. You can appreciate the final result is good. But again, when we analyze this case also, you can appreciate that this is the L6 ostium and the large amount of malapose stent studs that are hanging across this L6. You can appreciate here again. So in 3D reconstruction, you came to know again the wire is crossing proximally and there is large amount of stent studs. This is again after final kissing balloon dilatation and even after final pot. So again, so this is the benefit of doing imaging after two stent strategy. Whenever you are doing a final run after final kissing, you have to look at the side branch ostium with 3D reconstruction. You have to look at that. You have to have a figure of 8 without stent studs hanging. And if you don't have 3D reconstruction, you can have a longitudinal mode, and you have to have this part of the stent minimum. Again, the CTBP length was 3.1, and you have created metallic carina 2.6, 83% restore. This is again not acceptable. Then we started crossing the second crossing in the DK crush in the middle or towards distal, and proximally and the first crossing should always be proximal. And if you are successful in crossing the wire side branch in the proximal in the first kissing, then I don't think that there is a need of proximal recrossing. You can go towards distal so that you can have a minimum carina. And second important thing that can avoid this kind of side branch ostium is high pressure sequential dilatation. Three things can avoid this. One is either you go in the middle or towards distal, high pressure sequential dilatation. And the third is that you have to choose your stent, that side balloon size according to the distal reference diameter of the side branch. So this was again proximal recrossing. Now this was another case in which we did a left main bifurcation, and this was the final kissing, and this was the final result. Again, angiographically beautiful result. But when we go ahead again, you have got a side branch ostium and a new metallic carina that you have created. So this is again not acceptable. So let me tell you how to go about it. So this was another case in which we did, it was a post-PCI LAD, there was a instant restenosis and left main bifurcation lesion. So in this particular case, we went ahead, we did a pre-PCI run to look for the cause of instant restenosis. It was intimal hyperplasia and underexpanded stents. Then we measured the CT angle, it was 45, CTVP length was 1.6. Then we imaged the LCX. When we imaged the LCX, we came to know that LCX is quite tight with a amount of calcium also. Then we planned for a two-stent strategy, and we did a two-stent strategy, and we did a decay crush. In this particular case, we made all effort to cross either in the middle or towards the carina during second time. Before second kissing, we did a sequential high pressure dilatation, and this was the final result. Again, angiographically, good result, and to be seen in the OCT. In this particular case, we had a perforation in this LADI. You can see the deformed stent, and we placed a graft master here. And when we did a OCT run, this was the proximal LAD, mid LAD. As you can see, here we are getting a 72% expansion. Post PCI, you have to look for the apposition. It was well apposed. Expansion was 72, not acceptable. But again, as I told you, we have to use this software smartly. When you select totally from left main to mid or distal LAD, the expansion will never be accurate. You have to select the left main to LAD, proximal LAD, then you have to separately, measure the expansion at the proximal LAD and mid LAD, because this software uses the proximal and distal reference diameter to calculate the expansion. In this particular case, as you can see, there is hardly any new metallic carina. This is the L6 ostium. This is a graft master that you can see that this is how it looked like on OCT. And when you are coming at L6 ostium, now you can see there will be hardly any stent struts across the L6 ostium. You can see. So the CTVP length was around 3. There was no metallic carina, and when you measure the expansion from left main to proximal LAD, it was 82%. And you can appreciate the side branch ostium. There is hardly any stent studs hanging. So here the OCT 3D reconstruction helped us to assess our results. So whenever we are going for two stent strategy, final main branch pullback, you have to have 3D reconstruction. You have to look at the side branch ostium. It should be free from the stents so that we can have a good long-term outcome. In cross-section, we have to look for this figure of 8. It should be free from stent studs. This was the LAD ostium. This was a stent-only view. You can see the left main stent. This is the LCX ostium free from any stent studs, and this is the image of the graft master. We have given this name as a eclipse sign. So again, as Goran said, in left main bifurcation angioplasty, we should make it simple. We should add the layer of complexity as we do it, and when we are using imaging, in particular for left main, OCT is the fantastic modality, except for ostial left main, and with 3D reconstruction, you can get to see the side branch ostium. You can appropriately optimize your final results. Thank you very much.
Yeah, thank you, Ankush. This was an excellent presentation. It just shows how complex interventions need proper imaging, and probably that can help to decide the strategy, optimize the results, and look at good long-term results. So this was a fantastic depiction of how OCT can be so helpful in the cath lab in these complex procedures. Dr. Praveen Chandra has joined us. We'll go on to his talk, and then we'll have the comments together. Dr. Praveen Chandra, welcome to the session. A very good evening to you. A brief introduction for Dr. Praveen Chandra. He's the chairman of Interventional and Structural Heart Program at Medanta Hospital, Gurugram. He's recognized as one of the leaders in angioplasty in the country. He's proficient in the use of almost all the new devices and technologies. He's involved in numerous national, international trials and research, and has multiple teaching and training programs for the upcoming interventional cardiologists. He's a faculty at prestigious national and international conferences and workshops. He's also a recipient of the prestigious Padma Shri Award. Dr. Praveen Chandra, welcome, and if you'd like you to give us your talk.
Thank you, Dr. Basarge and Dr. Prashant. I think this was a wonderful presentation, which I heard right now from Dr. Ankush, and very, very exciting, I must say, and I must congratulate him for the beautiful images which he has acquired. And I must see his presentation again sometimes, because I could only see level 1/3 of that presentation. But I'm sure this session is doing so well, and I feel sorry for myself that I missed a lot of things in this session. But certainly, I'm sure you must have discussed about the left main bifurcations and so many other details which are there. So I'll take you through some of the case-based learnings in left main bifurcation lesions. So we all know that the strategy for bifurcation lesions it's not only one. There are multiple options, and many times one option is equal to another option, or one option is equal to two options, and maybe one is better than the other. So it's not a rule. So we have to make our decisions based on individual patient anatomy and also individual patient clinical profile. That is very, very important, because sometimes the circumflex is completely infarcted, sometimes the LAD is completely infarcted, and still you are treating the bifurcation. So stenting crossover LCX with optional kissing balloon inflation is one of the commonest strategies, I must say, and it is not a bad strategy, I must tell everybody. It is a very good strategy. We have seen it working many, many times. So you don't have to do a dedicated bifurcation stent or a DK crush or etc. in all left main bifurcations. T stenting, tap technique, V stenting is another way of handling this problem. SKS was popular at one time, not so much right now. Q-lot and DK crush techniques are very, very common. But ultimately, what again, as Ankush was also mentioning, that we have to make things simple. Simplicity is the most important thing which you have to do again in a left main bifurcation lesion. So simplify the complex. Do not do ad hoc. Try to do ad hoc PCIs at least in left main bifurcations, unless until the patient is in cardiogenic shock, or maybe patient is very unstable. It's better to have a plan. Make a plan and then execute it, and try to do things in the most simple ways. That is my advice. So before doing a case of left main bifurcation, that is very important. You can do 100 things in a procedure, but many times you want to do something and the material is not available. Sometimes the the stents are not available. Sometimes the balloons are not available, etc., etc. And maybe debulking devices are not available. So the steps of the procedure should be decided. The hardware required should be available, and try to make it available before you actually take the case inside. and then only take the patient on table. So when left main bifurcations, definitely, or left main as such, we should not try to take chances, because it is a very, very important vessel and cannot be handled without any make planning. However, now let me take you to some cases, and this is a patient where there is a tight lesion in the right, which is there, and then there is a lesion extending. I don't know why it is going back. So the lesion extending, into the LAD from the left main, and okay, fine. Now you can see that this again is a left main, but this left main is a different kind of a left main, where there is right artery is also diseased, and the left main to LAD is a very, very complicated situation. So how do you deal with this? Of course, here the plan is to first fix the simple lesion, which will give support to your complex intervention of the LAD. And here what we do is we fix the right artery first. Once you fix the right artery, make a plan of treating this left main to LAD lesion, which is very, very complicated. So how do we do that? It is a calcified lesion. We have to fix from the distal to the proximal. Calcification is there. We try to do in this kind of situations, you have to do a rota. Many people will say, okay, I'll go ahead and do a IVL. But in here you see that the lesion is very, very tight, very, angulated. Putting a IVL catheter will be almost impossible over here, unless until you do some debulking to start with. So in this kind of situation, we do a rota using a 1.25 bar, and then we go with serial balloon dilatations. And what you see is that the lesion is not expanding. So that is the time when you start thinking that maybe I will use a IVL. But IVL again is a slightly bulky device, and you can see that the balloon is not going distally. So what we do, we go ahead with another burr, which is a bigger burr, 1.5 burr, and then do a burring. And after that, you start dilating again. Most of the lesion is getting dilated, except in the proximal, still there is a residual, which is not going away. You go to high pressures using a smaller balloon, and that is the time we were thinking that we might have to upgrade now to IVL in this proximal part of the LAD, which is near the distal end of the left main and the proximal part of the LAD. So we do balloon dilatations. Then at this stage, we thought that why not just do a cutting balloon, because the cost will be an issue. So we took the cutting balloon, and we were successful in pushing the this limits of this lesion, and we were, as you can see proximally, we were able to expand it. And then of course we put the first stent, and in here you will see that imaging was done. Saw a flap. I don't think anybody will leave that flap distally. And in the proximal segment also, although we knew we'll have to treat it right going into the left main, and we saw that of course the lesion preparation has been quite reasonable in the proximal part, with a lot of dissection as well, which is what we wanted. And in this situation, we have to still further expand the stent, which we will do eventually. So finally, we went ahead, put another small stent distally, and proximally a stent from the left main into the proximal part of the LAD. So from left main into the LAD, straight stenting, no need to do anything for the circumflex, because circumflex is small. It is occluded distally. So that is the simple solution. Don't try to put any wire or anything in the circumflex. And final result is quite good, and we were able to fix it. So what I'm trying to say is that a left main bifurcation does not mean always a left main bifurcation. You can treat it with proper thinking and going ahead with the proper strategy. So in here, what we did, multiple steps were done, 2 rota, 1 cutting balloon, multiple balloons were used, OCT, 3 stents, and of course, lots of time and patience. So having patience and time is very important in these kind of cases. So you are all are experienced operators here. One would never try to do it at the last case, or when one is trying to go home and the car is waiting in the portico. So we have to do this. And now another interesting case, which was not a left main, but it has to be treated sometimes like, you have to be prepared for the left main. So what will you do in this situation? This is a almost osteal, exactly osteal lesion of the LAD. And in here, we try, most of the times, we try to put a stent very tight fit. And that is our, internal feeling many times, just to avoid that we put a stent from the left main into it. But many times we have to actually do that. So in this case, we, and I thought it is very simple. My colleague said, okay, let's finish it quickly. I said, fine. And so he went ahead, put the first stent into the ramus, which was tight. And because, we have to put a stent maybe from the left main, or if we are lucky, we will be able to put a stent bang at the ostium. So we did the first stenting was done into the ramus. And then the second stent was then first after the pre-dilatation, we looked at the vessel. The vessel was looking okay. So we decided, okay, we'll have to put a stent and try to put it right from the ostium, because in this view now we see that the nipple is reasonable. We can attempt to do this. So we did that, and this is the expansion of the stent, which is still not expanding fully well with the expansion, with the stent balloon. So we thought, okay, there is no problem. Looks very nice actually. So then I said, okay, you will be able to finish in 2 minutes. And I went away and said, okay, post dilate this. And while he's post dilating, you see what happened. This is a reused balloon he took, I don't know, because of the hurry or whatever. And then the balloon ruptured. So once the balloon ruptured, then what happened was most interesting. You see what happened now. While he was pulling the balloon out of this, the material actually pulled the stent and actually deformed the stent. And now we have a piece of stent, as you can see, in the left main. So from the, from the pan to the fire, we are now in a more difficult situation. Suddenly I get a call, okay, come and see what is happening. So when I came, this is the situation. I said, now you have created a mess. So this mess is that we have a wire which is in the ramus, which is okay. And now we have a stent piece which is hanging into the left main. What will you do in this situation? So we have to fix this problem. To fix this problem, what we do is we have to now go into the circumflex. So we try and go into the circumflex, because we have to take care of this piece into the left main, into the distal left main, which has to be plastered somewhere. So to do the plastering, we have to put a stent in the left main. And then we said, okay, what we do is, let us try and do this. So we put a wire, we dilated this whole piece, and then we put a stent from the left main into the circumflex. Now we are making it as a bifurcation. So we did this, and you can see we also did the imaging. So you can see the imaging, and here you see this hanging thing in the left main. The entire, this crumpled stent inside the left main. So we went ahead, and now I'll show you. This is the dilatation first of the stent, which is crumpled, because sometimes you may not be able to take a balloon inside the crumpled stent. So we took a new balloon, dilated this piece of stent inside the LAD, proximal LAD, and then we put a stent from the left main into the circumflex. And then why we took out the wire, because there is crumpled pieces inside, and sometimes the wire can get stuck inside those crumpled pieces. So we took it out, and then we recrossed this whole thing, did a kissing dilatation, and finally the piece was completely crushed, and we got a good result in this situation. So basically, from a simple osteal lesion, it now then became a distal left main bifurcation. So this is how we handle this. Then decay crush in left main bifurcations, most of you must have already discussed this during this session. This is a typical case for a distal left main bifurcation using a decay crush, because the tightness of the LAD and the circumflex both are severe, and we are committed to a 2-stent technique in this case. We cannot do a 1-stent technique in this kind of situation. So the anatomy decides which way we have to go. So we do a pre-dilatation, and then of course pre-dilatation of both the vessels, do the first stent, and all the the regular steps of a DK crush, and we get a good result in this situation. So this is how a DK crush will help in this situation. Then a tap technique in the, now here, why do we do a tap technique? Let me just show you. So here what is happening is that the LAD ostium disease is not too tight. So which means we will be able to put a, we put a wire across this, there will be no problem, and we will be able to do this with a tap technique. And it's a very straight looking LAD, not very tight. It won't get occluded when we put the first stent in the left main to the circumflex. So we first stent is put from the left main into the circumflex, and then a port from the left main to circumflex is done, and then we recross, do a kissing balloon inflation, and then we do a tap stenting like this. You can see that we do a tap and then post dilated with the high pressure. So selecting the technique is basically dependent on what kind of anatomy you have and whether you are committed to a 2-stent technique or a 1-stent technique. I think this is something which is not so difficult to handle. Maybe you can see it clearly that there is a ulcerated plaque in the ostium of the left main and going into the body of the left main. And here we have also a disease in the circumflex, which is there in the distal segment. So of course, we go ahead and treat the distal segment first in the circumflex, and then after we stented the circumflex, you can see here, then predilate the LAD in the left main, and the patient was little unstable, so IBP was inserted in between, and left main to LAD stenting was done with the good results. So basically, I think, left main dissection. Now, this is something which I would certainly like to show you. Again, a very simple case. It is the end of the day. And I thought that nothing is going to happen in this patient. We will be quick. So we put a stent in the RC was first treated, definitely. And the RC wire went in very easily. So we said, okay, let's fix the LAD also. And the LAD was looking very straightforward. So we put a stent here and post dilated also with a 3 millimeter balloon, high pressures, post stenting, checking the stent looks good, no problem. And what you see is that the post dilatation is further done, again quite okay, no problems, good result in the LAD. And I said, okay, thank you very much, I'm going home. As soon as I returned my back, he did the final shot, and what you see is this. This is a completely ruptured, left main, maybe because the wire was actually into the distal, in one of the branches where it got stuck a little bit, and this guiding went inside. So immediately, the patient started becoming a little unstable. So we quickly put the wire, which was a little bit tricky here, and then put the stent and restored the LAD and circumflex flow, and the post dilatation in the left main, and the final result was quite nice and good. So this is something which can happen when we are pulling out the wire and the wire is slightly stuck, because these BMW wires sometimes have the stickiness distally, and then it leads to a problem. So the OCT was done in this, and then a third stent was done between the 2 stents because there was some residual dissection flap in between. So this is the third stent deployment between the 2 stents, and everything looks nice and fine. Final OCT run. So I think, these are the cases which keep teaching us many, many things in between. And as I said, that, individual decisions have to be made according to the, the anatomy, the clinical condition, and of course, many, many small things like calcification and so on and so forth. So I think I'll stop here. Maybe these are enough number of cases, and maybe we can have some time for Dr. Ankush's presentation as well. Thank you very much.
Thank you, Praveen. It was a very nice case presentation and very informative. If any questions are there, we can take up few questions, either for Ankush or
Just comment. Chandra's mantras were great. That was really catching, and we'll remember them.
Thank you.
Prashant. Any comments from you?
Yeah, I have a question for Ankush, if he's around.
Yes, yes.
Yeah, because he first case which he has shown in the OCT run of the final slide, one of the areas, the wall, the MSA was 4.3 or something, 4.0. So, did you do anything for that? I thought it was.
Yeah, it was post-dilated.
Because
I actually have given slides accordingly. I thought, let us discuss what is to look for in OCT for bifurcation angioplasty. And obviously, we have to do appropriate expansion. We have to look for the MSAs like 8, 7, 5, 6 at different points. Definitely, you're absolutely correct. We did post
I thought that was a very important point, because if you don't get an adequate MSA, you may not get a good result. And the third case, I was listening to one of the lectures by the pioneers of this decay crush. He told that when you put a side branch stent first, before crushing the stent, dilate it once again with a NC balloon of the same size NC balloon. So this is typically true with a circumflex side branch. When you side branch is circumflex and you put a stent in the circumflex, after deploying the stent, put a NC balloon in the circumflex and deploy it properly at a very high pressure, and then go ahead with crushing the stent. That is the point which he had stated. Probably that was the reason why in the third case you had a restenosis later. That might be one of the reasons which can contribute. If you don't deploy the stent originally well, and this is very true with circumflex ostium. That is just one additional point I thought I should tell my colleagues, and what their opinion. I can take their opinion also, because this is a very nasty lesion. Once the circumflex comes back with a restenosis, then it becomes very difficult to treat.
You're absolutely correct, and again, that's absolutely correct. And again, in that particular case, as you saw that after final kissing of the case, and during the final run, we saw that a large amount of stent studs hanging on the side branch ostium. That should not happen. Again, then we retrospectively saw what can be the reason. Either we are using small size balloon, number one, or we are not doing proper sequential high pressure dilatation. And we actually found that the missing point in that case was one was a too much proximal recrossing, and second was not a proper sequential dilatation. And after that, we learned from it, and we changed our practice in two-stent strategy. That these are you are going for a complex intervention. You are doing decay crush, and you are finally leaving this large amount of stent studs over side branch ostium. Not done. You have to have a side branch ostium free from stent studs, number one, and number two, you have to have a minimum metallic carina. Otherwise, we'll have a side branch ostial restenosis. And I found that it's a very important step, sequential high pressure dilatation. And usually what I've seen that even myself also at the end of decay crush, when you have stuck in some difficult lesion at the end of 1 or 2 hours, you may miss that, you may forget that, but this is a very important step. Otherwise you'll have these kind of outcomes.
Ankush, I mean, have you find any difference in the stent platform as far as the overhanging of the struts are concerned across the L6 on OCT?
Not exactly, sir.
Any stent?
Exactly. So when we are doing a provisional stent strategy, we cannot control the amount of stent studs across the side branch ostium. We cannot control that. When we are putting a stent in the main branch, in provisional, we cannot control that. But what we can do is we can see whether it's a link-free side branch or not. If we have got any link that is connected with the carina, and then it says that you will, when you are going for a kissing balloon, you will end up with having a good amount of inappropriate stent apposition. But what how we can use OCT is that first we can identify the type of side branch ostium. Second, it can help in crossing from distal, and we can have a better side branch ostial orifice. But it depends whether you are going to go for kissing balloon inflation or not. As far as stent platforms are concerned, that most of my cases, they had a onyx, resolute onyx, and few are having Zines. In resolute, you have a peak-to-peak link and a 2 or 3, I think it's 4 links. But it's by chance, like the study that Okumura did, there is 50% of chances that you will have a link-free carina. But that is by chance. You cannot control that. Only thing that you can control is distal rewiring by using 3D OCT reconstruction.
Ankush, there is a question that does this link across the ostium get away with kissing balloon?
Again, if you have got a link-free carina and you are going distally, you will have a complete dilatation, and you will have a carina. You will have a stent-free ostium. But if you have a link that is connected with the carina, in that case, you will have a hanging stent studs even after kissing balloon inflation.
Okay.
A question to the whole panel, not directly relevant to this topic, but say you talked about post-stent assessment for distal edge dissection, medial dissection or long dissection. But suppose you don't have an imaging, or many times it happens occasionally that the imaging stops working by the time you are finished with the case. Then what are the angiographic visual criteria whether to stent that hazy looking or doubtful looking segment or not? This is open to the whole panel who are highly experienced.
Praveen, what is your take and advice?
You are asking me?
Yeah, Praveen.
Anyone who is ready to take.
Pura has asked the opinion of senior panel.
Shall I put it again? Yeah.
You can put it again.
Suppose we assess the distal end of the stent for dissection by imaging, but suppose sometimes it happens the imaging stops working halfway through, or you don't have it at all, and you suspect there is something wrong at the distal edge. What are the angiographic visual criteria where you would leave that, or where you will put another stent?
I mean, basically, let me tell you, the criteria are the same. If you find consistent haziness, despite you have given nitroglycerin, despite you have, waited for 5 minutes, if the haziness is consistently there distally, or if you find a dissection which is clear cut in one of the views, I think it is generally reasonable to put a stent over there if you don't have imaging. If you have imaging, then certainly I will say that you should do imaging, because sometimes very tiny dissections can be left back.
Any role of FFR?
I don't think FFR has much role in this unless until you start looking at something which is a big spiral dissection which is limiting the flow. Then it's already obvious. Then you don't need to do anything.
Right. Thank you.
Prashant, what is your take?
Yeah, if there is a haziness post stent, distal edge of the stent, either it is a dissection or sometimes rarely an intramural hematoma or a thrombus. In any of these conditions, if you are not sure and it's a stent which is in the proximal LED or something, then probably you have no choice but to put a stent, because you can't take the risk of leaving that haziness clinically. My question to Dr. Chandra is, in left main stenting, what is your imaging modality of choice? Is it IVUS or is it OCT? Okay. Because I find IVUS much more comfortable. Most of the studies are with IVUS. OCT has its advantages, but I think IVUS is better. That is what I feel, but I want your opinion and the panel's opinion also.
So let me give you an answer, which I do actually. This is a very practical answer. So practicality is, if I have to assess before the stenting, I do IVUS. If I have to assess post stenting and looking at something, whether the stent is fully, kind of having a haziness or some kind of a dissection or something like that, then I go with the OCT imaging. So post stent, it is OCT which is better, and pre-stent, it is the IVUS which is better. However, if I have to just look at the stent expansion only in the left main, in the body of the left main, or into the proximal part of the left main, then I go with the IVUS because the images are then much better compared to OCT.
I have one question. I'm Kushal Pujara. Just simple, straightforward procedure. One stent strategy, LMS to either LED or LCX. With there is no disease in the side branch. Would you open the stents of the kissing balloon at the end, or you just cross over stent and leave it alone?
Anybody wants to answer that?
You can answer.
Okay. So what you are asking is that if you have done a crossover stenting, whether you would do a kissing balloon after that or not. I mean,
Yeah, either cross over to LMS to LED or LMS to LCX, whatever.
Yeah.
So would you prefer kissing balloon or no?
Yeah. So for whatever crossover stenting. So if there is no obvious reduction of lumen, and if the vessel was not diseased at all from the very beginning, and you feel that the flow is absolutely fine, you can even leave it. However, the trend has been like this. Initially, we were doing it without doing a kissing balloon. Then there was a big trend that every crossover stent has to be kind of kissing balloon has to be done. But now I think it is divided. It's not that you have to leave everything or you have to do everything. You can depend upon the situation of each bifurcation, depending upon the size of the vessel, depending upon the viability of the vessel, of the second vessel, and also depending upon whether it was diseased and how much it is looking after putting the first stent. I think this strategy is a very practical strategy, and it works quite well.
Especially doing pot in left main stem, you distort the stent architecture, especially LMS pot. And then the side branch, your stent struts are not like ideal. There are distorted stent because of pot. So in that case, do you prefer to open the stent struts in the case of future access required, or you just leave as it is?
I generally leave it, like 80% times I leave it, because I do only when we feel that the side branch, either it is not important or it is quite big, it is not diseased, then I do a crossover stenting. And that is why, it is most of the times it is quite okay to just leave it like that.
It is more complex.
Essential.
What is your
more complex in the L6 dominant. When L6 dominant, and you have to put stent across LMS to LED, and then you find some disease mid LCX, which is borderline disease moderate. So in that case, whether to open the stent struts or just leave as it is. Like dominant LCX, large LCX, not the non-dominant and the small vessels.
I think there is no evidence available for benefit of routine kissing balloon dilatation after crossover imaging, crossover stenting. So again, as Dr. Chanda said, it's a case-to-case basis. Like routinely, I don't go for kissing balloon dilatation after crossover stenting until unless you see a significant side branch ostial compromise, number one. And even in that case, we usually go for its physiological significance, but it's usually operator dependent. There are a few operators, like if you're dealing with left main to LED crossover stenting and you have got a dominant L6, one may like to go for it, but again, if you are doing a pot in an appropriate manner in imaging, we actually see that you open the side branch ostium quite well.
Thank you.
Any more questions from anyone?
Yeah, I think this is a very good session. I think it has given us a insight into left main interventions and imaging and techniques, and we got a lot of tips and tricks from the testing speakers. So thank you very much to all of you. Thank you very much to the panel. Thank you very much for everybody who's attended this session. We'll close the session now. A very good night to all of you.
Good night.
Stay safe.
Okay, bye, Praveen. Bye. Ankush, thank you very much.
Thank you very much, sir.
Okay.
Bye, sir.
Thanks, Basarge. Thanks, Parvinder, and thanks, About People. Thank you very much.